We did this study in Sylhet district of Bangladesh, and it was conducted by the Projanmo Study Group, and it is a partnership collaboration between Government of Bangladesh, International Center for Diarrheal Disease Research Bangladesh, Child Health Research Foundation within the Dhaka Shishu Hospital, precisely the microbiology department, and we work with a local NGO that's name is Shimanti, and of course the Johns Hopkins School of Public Health of Johns Hopkins University, Baltimore, USA. So this is the study area. As I said, it's in Sylhet. It's the northeastern part, and we know that Sylhet is a relatively low performing area, consistently low performing area in terms of health and family planning indicators. And we work in basically 3 sub-districts. This is a very remote areas of Sylhet event to identify pregnancy. And then the birth identification, that's very important for this project. We wanted to identify the births as early as possible after delivery. And then there were some scheduled postnatal visits. In fact, there was 10 postnatal visits in 2 months' time, 3 visits in the first week of life, and then 1 visit every week for the subsequent 7 weeks, so total 10 visits. And then during these visits, the community health workers actually assess the baby using the World Health Organization, IMCI like algorithm, and then if the baby was found sick, the baby was referred to the nearest designated health facility and for enrollment and management. So there the referral is come into the. You can see that there is still some home visits. These are the old, the methodology home visits. That is the we used to do in the past. That the community health workers made some targeted visits. That is called the expected date of delivery tracking. So based on the EDD, they made some visits to the home. It is the conclusion. So these has the real some policy implication. This is possible. If we really want to do, we want to make a early postnatal visits. If we want to refer the sick babies to the health facility, that's possible, and we can really effectively use the cell phone. Not much, the voice call. As I recall that Alan made this point that voice call is the most important power of the phone, and we use that. So voice call, interactive communication with the family and between the physician and other project staff, program people can really make the difference for the benefit of the children and of course the mothers.
Foundation for annual program review of sector-wide program approach. We have now our 3rd SWAP or sector-wide project approach in our country. It is one of the world's largest SWAP program. So this SWAP, for midterm review, there is a suggestion that we need a routine health information system strengthening to make the decision making, evidence-based decision making. So in 2009, an innovative integrated approach towards HSS strengthening was started. GHS supported Ministry of Health and Family Welfare to develop a central electronic data repository called the National Database. What we use DHS2 version 2.0.1, and the most earliest version of DHS2. The aim was I underlined that portion, to bring gap between the fragmented systems by bringing together the data from various databases. That was very challenging because the various databases has various weaknesses and they don't want to expose their weakness to sharing the data. So there is a lot of resistance, and we have a huge resistance from every directorate. They don't want to share, they don't want to show that data. So convincing them that we are not exposing their weakness, we try.
A center owned by the Ministry of Health and Family Welfare. But still, we don't want to miss the opportunity of interoperability. So if we like to do that, we want to ensure one thing. One is standardization, and another is to have an interoperability framework. So actually, this is our idea. For example, if the number of divisions, districts, sub-districts, unions and wards in Bangladesh, these are dynamic because the number will not remain constant all the time. Then one organization should be responsible to maintaining an updated database. Second, the number of health organizations in the government sector, in the public-private sector, in the NGO sector. So these are also dynamic numbers. These will change over time. So there should be one organization responsible for maintaining the updated version or list of this. The third thing is that we need to maintain a database of the health workforce. And health workforce doesn't mean that the health workforce only of the Ministry of Health. Health workforce for the country. So there are many self-employed people even. There are informal healers and they also matter. So we actually want to have a registry of all the health workforce working in the country. Finally, we have the clients, the citizens. So we need to maintain a registry for all the citizens. So these are isolated things. Actually, we want to maintain one independent electronic registers for all the different things I have mentioned. Now, the ministry actually made I think we made progress. In some of the things, for example, we have got the health workforce registry, we have the health facility registry, we have the geolocation registry. And we are progressing for actually making the client registry. So by this time we have got 98 million records. But if you actually review the situations in the entire Bangladesh, in the election commission there are 95 million records. In the birth and death registration project there are 105 million records. We have got 90 million records. So if we combine all those records, we may have actually about 110 or 120 million records already in existence. So now our job is to actually complete the remaining persons into the system. That means 150 million or more. And the sum of the, because all the different agencies, they do not maintain all the fields. So the gaps in the data fields we have to recover. So now Ministry of Government has decided that we'll work together and we'll make one combined database. And that would be actually every citizen will be identified by unique ID system. And as our ICT advisor told, that this will be, every citizen will be identified by biometric identification method. One will be by fingerprint, and also for the children, we'll also need iris. So this is the plan of the government. Still, there will be many organizations, maybe outside the government, private sector, NGOs, they will want that they will create their own database. They will maintain the data into their own servers. So how this data will be interoperable, will be usable with the government system, and how we will be able to make relationship between the different kinds of data.
3 C's that I usually talk about: continuity over time and place, coordination between providers who are taking care of a client, and collaborative care is the third one that you can't see there, but teams of providers working together to provide services. And these are all leading towards better health quality for the client. And then we also have another set of reasons around better health system performance and efficiency. And this is where you see lower costs and around information access, visibility, and reuse, improved monitoring and evaluation capacity and abilities, and reduced duplication of services. There's a lot longer list that we could develop here, but I think focusing this in on quality and health system performance is what we really want to do. Research, though, has actually not demonstrated enormous benefits of the use of e-health to improve quality, which is kind of interesting. It's similar to where we are in the mHealth field, that evidence is still in a rather nascent stage. There's definitely some exceptions, but I like to use the IOM's framework of quality, the domains of quality, as the basis of this. And we're still trying to explore in each of these and improve our evidence. But this leads to the next question that I talked about. Well, why is this so difficult? So we've all are expecting that e-health is going to be improving quality and health system performance, but it's been difficult to achieve. And part of the reason that we believe, and this is true in the US as well, is that despite the fact that we have lots of e-health systems and electronic health records implemented, the fact that they're not interoperable is why we aren't achieving those 3 C's, the continuity, coordination, and collaboration.
So I'm going to talk more about what I call pragmatic interoperability. So what are the other factors that we have to think about when we're talking about getting agreement and working with each other? So one aspect is this basic idea of data interoperability. So I like to kind of describe it as common forms. Are we asking the right questions in a common way? Common indicators. This is kind of what John Payne just kind of mentioned in terms of concept dictionaries. Are we talking about the same places? And if we are, then we might have this ability to kind of talk about common data or share common knowledge.
A visit to all the married women of reproductive age and with a register and with all the information including their family cell phone number and everything. And there is also counseling going on, and whenever the mother was, one of the women became pregnant, then there was additional counseling at least 2 times in antenatal period for birth preparedness, and then also making this communication and making
Earlier, because government is taking this on, government in some province. So when this was being discussed at length, is like whether or not this can be scaled up. We did come up with the calculations for the cost and everything. The cost for scaling up this registry, and we did it per unit, that is per child, was 8 cents without the incentives. Now adding on the incentives for the vaccinators, it added another 20 cents to it. And then if you build in the incentives for the parents, it adds around another 40 cents. So overall, like, the calculation, the way the government was comparing it is like government spends around $18 to immunize a kid. Now looking at that and adding on another like 60 cents is not a big cost when you're already spending $18. Even though they said, okay, this is something that is doable, but they were like, they want to deploy the registry. And they only want to give the incentives. They want to keep the incentives for the vaccinators and not for the parents at this point in time. They want some more data, both from the urban and the rural setting, to make that decision.
Most of us who are working on these pilot projects that we suffer from, that when our health assistants or Brakshastro Shevika were entering data in the mobile, it's not that they actually stopped collecting information in their usual registrar, because program demands that from that. So as a researcher, we are actually intruder. We are not the routine program implementer. So we went that and we got the permission from BRAC and Professor Azad, that health assistant, Shastro Shepikul. So they're doing actually in a way double work. So I think you raised a very valid question, and that actually takes back to my point, what I actually kind of request to the audience, Elaine, Mridul, or Professor Azad, that all these pilot programs we are doing in Bangladesh, and we're talking about all these successes which was mentioned by the health minister, that we should actually closely look at what are the unintended problems.
The health worker that this is their property, but then they will have to take care of it. If it is lost or damaged, they will have to pay a depreciated amount of it. So that is the negotiation that we get into. But after 4 years, if you ask me, like 4 years of project, that will we take it back from them? I don't think so we will, because the depreciation value of the phone is such that I think it can remain with the health worker at the end of the project.
Thailand's strategy for adopting e-health standards, may I call on Dr. Bunchay Kidsanayotin. A big hand, please.
I would like to take in 3 points. One point is that to give you the landscape or the situation of the interoperability and standard in Thailand and e-health system or health information system in Thailand. The second one is that I think many of us come from the different fields and are not maybe have a different language or the understanding about the interoperability and standard. So I think it's good to be more in the same place what we are talking about. For countries, for every country in 2010, you can see that it composed of 6 components. Every component is very important. One of the component is the interoperability and standard. So you can see that to be success in e-health or health information system, health interoperability and standard is one of the 7 major components that every country has to be achieved effectively, consistently. And the important thing is that not only exchange, it has to be used. It has to be very useful or usefulness. This is what it means by the interoperability. It seems very easy to talk that why don't we have the system interoperable? But you can see that this is the 5 level of the interoperabilities. The interoperability is easy to say, but it's difficult to achieve.
the guest of honor might arrive. So might as well use the time here to ask Dr. Bunchay if you have any questions. The floor is open. The process by which they classify and give unique identifiers to their drugs. I think we need that in the Philippines so that we can have a complete view of the life cycle of a drug from registration to procurement to administration to adverse event documentation. Without a unique identifier for the drug, all through that life cycle, you won't be able to do a good. You won't be able to get a good picture of the effectiveness of a drug in your country.
Also, what do you think of e-health for the country like yours?
Electronic medical record, because it can be mean many things, and we struggle for that. If we use the hymns, that's the first question. The second question is that I jealous Philippines, because we have the leadership. Philippines have the leadership that no, this is the issue that can leverage the health system.
Assalamu alaikum, and thank you all for been informed. I wasn't able to attend any of the earlier sessions, but I've been informed that this has been a very successful conference. For all of you visiting from other countries, I would like to welcome you to Bangladesh. As you've heard, in Bangladesh, 5 years ago, we embarked on a journey which we called Digital Bangladesh. Our goal was to create a digital information-based society and government. Now, 5.5 years ago, the government of Bangladesh did not have anything digitized. If you wanted any government records, any government services, you had to go to the nearest city, especially people from the villages had to go to the nearest city, stand in line at a government office, and even for healthcare, they had to go to the nearest hospital. Most of the basic healthcare in Bangladesh is provided by the government, but the hospitals were based mainly in the smaller towns, and there was no system of information sharing. Most of the leading technology, most of the leading healthcare advances, best doctors resided in Dhaka, not out in the cities. The whole goal of Digital Bangladesh was to take services to the doorstep of the people, to benefit not just the people living in the cities, not just the middle class, but everyone, including the people in the villages, down to the smallest village in the country. And so toward that end, we started on an ambitious program of digitizing all government services. That was one of the 5, I call it, aspects, the 5 distinct divisions of Digital Bangladesh. And of course, healthcare was one of the critical sectors in that. It was very interesting that when we started, the health ministry was one of the first ministries to wholeheartedly embrace the concept of digitalization. You see, when we started with this concept, we discussed various alternative options of how to digitize government services, and it was decided early on that we would let each ministry handle its own digitization, since each ministry was already allocated the resources, the funds for what used to be called IT services. Back in the day, prior to Digital Bangladesh, IT services for a government ministry involved buying computers, setting up some printers, and that's it. So with Digital Bangladesh, we decided to set up the concept of a focal point, which was at the Prime Minister's office, to coordinate all digitization, but let each ministry handle its own digitization. So in that regard, under our previous health minister, Dr. Ruhul Haq, the health ministry really took the lead and was one of the first ministries to start digitizing their services. They were one of the first to set up a data center, their own data center, and they were one of the first to really start solving problems IT and provide IT solutions using innovation rather than just throwing money at the problem. To give you one example, and this is something that I was rather proud to hear, and this is a prime example of digital Bangladesh in action. This was something that the health ministry did very early on. So the Awami League government, in order to expand healthcare, our government has certain basic priorities that we believe are guaranteed rights for every citizen: food, shelter, clothing, and healthcare. We included healthcare in that because every citizen has the right to basic healthcare. That is a right. It is not. It's not a luxury. It should never be a luxury. So the government of Bangladesh, the government of Awami League, wants to guarantee every citizen access to healthcare. With that in mind, our government embarked on an ambitious program of building community healthcare clinics in every village in Bangladesh. In the last 5 years, we built 14,000 community healthcare clinics throughout the country. However, there we ran into one logistical challenge. That was a lack of doctors. There were simply not enough doctors to man all the community healthcare clinics in all the villages in the country. So we decided, the health ministry came up with a solution to that. Since most of the doctors were available in Dhaka or in the major cities, we decided that we would use, and this is where this conference is a prime example of what is possible using at the intersection of health and technology. So the health ministry decided to use video conferencing with doctors in the cities at those remote healthcare clinics. Patients could be interviewed and be diagnosed by doctors on live webcams in person, even though they were separated by hundreds of kilometers. Now, traditional video conferencing solutions were looked at, and they are very, very expensive. So the health ministry, on its own initiative, brainstormed, and they came up with a very, very simple and inexpensive solution. They allocated every healthcare clinic the budget to buy a laptop computer and an off-the-shelf webcam. And we used Skype, just plain free software, to set this system up. And it has been working brilliantly. So this has been one of the hallmark innovations and one of the typical innovations that the health ministry has undertaken. And this has also been a hallmark of Digital Bangladesh, that we have tried to come up with innovative solutions, because frankly, Bangladesh is still a developing country. We do not have the budget to throw at the most expensive solutions across the board. So we have very often come up with innovative solutions to problems, using inexpensive, off-the-shelf, custom, locally built IT systems to provide solutions which otherwise would have cost millions of dollars and foreign consultants. We have probably saved millions and millions of dollars in foreign consultancy fees alone. Our web portals that was mentioned, that has been another prime example. So again, we wanted people throughout the country to be able to access all government services and all government information. To that end, early on, one of the criticisms pointed at Digital Bangladesh was that, well, the people outside of the cities have limited access to computers and the internet. They will not be able to gain any benefit from digitization. So our government took the initiative that we would create what the concept was, and this was my concept initially, that eventually we would create a cyber cafe. We would build a cyber cafe in every village where the people of that village would be able to get access to the internet and thereby all government services. The village level was too far and far too expensive to go down to. We have over 60,000 villages in this country. So we decided to build them at the union level, which is the smallest local government division of our country. And the plan was to build what we call a union information center or digital center in every union within 3 years. We built them in a year and a half, in half the time. And so then the question was, how do we get government services to those union information centers? How do we make access easier? And the easy solution was to put it all on the cloud. You've all heard the term cloud is used frequently in the IT industry now. It's become a buzzword. But in our case, it really did make life easier. All government services reside in the government data center based right here in Dhaka and are accessible online from anywhere in the world, anywhere. And for every single division, every department, every ministry, we've been building these web portals. Every district office, every Zilla office, we've been building web portals for the local government to interact with citizens, to provide data, to have online forms for applications. And yesterday, as you just heard, I inaugurated the opening of our national web portal, which encompasses now 25,000 websites. It is, and we checked online, it is the largest government portal in the world today, the largest. And you can access them all from www.bangladesh.gov.bd. From that web portal, you can access all 25,000 websites of the government of Bangladesh, including all local government offices. But coming back to healthcare and IT, right from the beginning, the health ministry has shown tremendous initiative, and I'm very grateful to our health ministry and all those involved for making it happen. In fact, one of the first international awards Bangladesh won for Digital Bangladesh was for the utilization of Digital Bangladesh in the health sector. During our term at the UN General Assembly, Bangladesh won the award, the South-South Award, for using IT services to improve infant mortality, for most significant improvement in infant mortality. And again, just to show you the level of innovation and how simple things can make such a big difference. It turned out to be such a simple system, but it made a tremendous difference in saving the lives of newborn infants. So the system that worked was a simple text message, SMS-based system to provide timely information to pregnant women around the country. So when a woman becomes pregnant, she goes to the local healthcare provider in her village or the midwife. They go online, they register her mobile number on the system, and they register her expected due date. And from then on, she receives timely and regular information via text message on what to do, what to eat, how best to prepare, when to visit the doctor, and so for prenatal as well as postnatal, as to what to take, what steps and what food to feed her child, when to take her baby to the doctor. If she has any problems, she has a number that she can call for help and get more information. And just this simple system alone dropped our infant mortality rate to where now it is the lowest in South Asia. Indeed, South Asia. And it was, again, IT, mHealth, using mobile technology and using a very simple, innovative system to make a huge difference in saving the lives of children, of the future generation of this country. So, of course, as you all know, I'm a techie by background, so I firmly believe in digitization, but I am rather proud to see the impact that digital Bangladesh, that digitization has had on the lives of the people of this country, both in the health sector as well as across the board. It has made a tremendous difference, tremendous impact to the everyday lives of the citizens of this country. To date, in the past 5 years, we have digitized 70 separate government services that used to be provided directly to the citizens. The goal is, in the next 5 years, definitely by the year 2020, which is one of the Awami League government's benchmarks, as per our Vision 2021 plan for Bangladesh, by then, all government services will be digitized across the board. Everything. Everything will be accessible online. All government data will be accessible online. All bill payments, stipends, what have you, everything will be electronic. That is the plan. With regards to the healthcare sector, one of the things we would like to do eventually is integrate a national healthcare database so that all citizen health records are available to doctors instantly. That is one of our goals. Towards that end, one of the primary things that is lacking, of course, is any kind of a national identity system to keep track of individual citizens. That is in the works. We are in the process of building a national ID system. It'll be a secure system. I'm sure most of you are familiar with the voter ID system that was developed several years ago. That was what I like to call version 1. So in IT, you typically hear version 1, version 2.0. So that was version 1. It was done quickly, it was done cheaply to make it cost effective. The voter ID cards, they are paper-based cards, so they have very little security features. The new national ID system that we're building will be electronic chip-based system with an electronic chip built into the national ID card itself. The card itself will be made of polycarbonate, so it will be durable. It's guaranteed to last a minimum of 10 years. So that especially the poor people in the villages don't have to worry about the card being destroyed by rain or getting lost and being misused by someone else. But once we have a national ID system in place, then it will be much easier to build the national healthcare database. Now, I'm sure all of you have concerns about security. So that, that is something that we are now in the process of looking at. Again, the version 1 systems that we developed for our government services, our priority was to digitize the services first. Security was required to be built in, but we did not focus on a holistic overall security plan. Our IT ministry now is in the process of developing a cybersecurity plan, and the national ID system, healthcare system, will all be required to follow that plan to ensure that our citizens' data and information remain secure. So I am, in conclusion, I'm very happy to see that such a conference is taking place in Bangladesh, because especially in the developing world, Bangladesh has really become one of the role models of using IT, adopting IT to provide citizen services, and especially with the health ministry having taken such a lead of providing healthcare services and digitizing healthcare services, and especially what has been a key concept of this conference is using innovative IT solutions to improve healthcare, to improve lives. in that regard, I would also like to share one small piece of information. Because of our success in Digital Bangladesh, we are now receiving, especially the coordinating body at the Prime Minister's office, which is the Access to Information Group, we are now receiving requests from other developing nations for our help in training them and teaching them how we used our solutions, how our solutions were developed in using IT, to use IT to provide citizen services. So Digital Bangladesh has become so popular around the world that other countries are asking us to help them adopt our version of digitization, to help them adopt Digital Bangladesh for their own needs. And I am especially proud of that. With that, I would like to thank you all for coming. I hope my speech was not too brief. Unfortunately, I'm not an expert on healthcare, I'm an expert on IT, but I believe that Digital Bangladesh and IT has made a tremendous difference, both in the general lives of the people of Bangladesh, but more especially in the healthcare of the people of Bangladesh. Thank you. Jai Bangladesh. Jai Bangladesh.
And I request my Honorable Director General of Health Services, Professor Dr. Din Mohammad Nurul Haq, to kindly offer this honor to our chief guest.